Immunotherapy, I think, has made a lot of inroads into a lot of tumors and in small cell lung cancer. So immunotherapy, as I was saying, in non-small cell lung cancer, we have PDL1, which is a biomarker. We do test for that, and if someone has high PDL1, we are giving even nowadays single agent immunotherapy. And we have patients who are treated with 3 to 4 doses of immunotherapy and are disease free even after 4 to 5 years of survival after stopping that. Yeah. For small cell lung cancer, unfortunately, we don't have any biomarker testing. So we have a lot of genetic testing which is available for the other variant, the non-small cell lung cancer, where we do NGS panels or the comprehensive genomic profilings, see the genes. In small cell lung cancer, though all this genomic testing has been done, the common mutations which are seen are P53 and RB, which probably are not of much use in choosing the therapy. And for the extensive stage, I think we have good data from 2 trials which showed the evidence of PDL1 antibodies. One is Durvalumab, other is atezolizumab. So these are the drugs which are added to the chemotherapy because chemotherapy cannot be given indefinitely. We stop chemotherapy. After stopping chemotherapy, we continue immunotherapy. So this is proven beyond doubt. So what we were doing earlier was only chemotherapy where the survival was very short. But after adding immunotherapy, we have seen that the lifespans have changed and we are seeing now survivals crossing 2 years or so even in extensive stage. What's the role of Durvalumab in limited stage lung cancer, small cell lung cancer? So this was the basis on which this drug received approval. This was the ADRIATIC study, which was a phase III multi-center study. And good thing about that, this was also having Asian patients. And this was for those patients who had the limited stage small cell lung cancer. And after treating these patients with chemotherapy and radiation, if they had a good response, who did not progress, they were randomized to receive either a placebo or a drug called as Durvalumab, which was very comfortable because to give once in a month with not much side effects of the chemotherapy, and it had to be given for 2 years. So we'll talk about the cost later. So this was evaluated with survival, and you can see the population basis, and it was balanced between both the placebo and the Durvalumab. And if you can see the survival difference, you can see the top curve is for the Durvalumab and the low one is for the placebo. You can see the survival difference. It's hazard ratio of 0.73, almost 27% reduction in death for those patients who have received this immunotherapy drug called Durvalumab. And if we can see this plot across the subgroups, majority of them did well when they were on this immunotherapy drug. And even the PFS was much higher for those patients who received Durvalumab compared to placebo. So 16.6 months to 9.2 months. So almost 80% improvement in the PFS compared to placebo. And you can see again the hazard ratio showing a 24% reduction in the PFS. So Durvalumab is, though there are I think 4 or 5 immunotherapy drugs which were tested in small cell lung cancer, this was the drug which was showing benefit in the limited stage SCLC. And as I said, this was consistently, even the PFS was showing benefit even in the subgroups where even they have received the earlier radiation and based on the prior chemotherapy. So one thing which was debated is whether to give prophylactic cranial radiation or not, but I think still there are ifs and buts, but given a choice, someone who is responding well, majority of us do opt for giving PCI in all the patients who have very good response for the chemotherapy and radiation. So for today, if we have RCTs which are showing plus minus, the majority of the clinicians, we are opting for giving PCI in these patients who are responding well. So again, the trials which have shown benefit in few set of trials which are in the gray area showing no survival benefit. But I think, as I said, the bottom line is going for PCI for those who respond is the dictum today. And adverse events, I think Durvalumab is a very much safe drug. So you can see that most of the side effects are because of the immune-related adverse events we see when the immune system is overactivated because of this drug called Durvalumab. We see pneumonitis being the commonest, rash, and the thyroid, which is most of the times manageable. So side effects with Durvalumab or any immunotherapy drug are very much manageable. So pretty much safe drug to be given for 2 years. So the conclusion of this ADRIATIC study was that Durvalumab is the first and the only approved immunotherapy drug in the limited stage SCLC, and this has shown improvement both in the OS and PFS, mainly for the reason that the limited options available for treatment in the SCLC early stage, when we are giving with a curative intent, even after giving the chemotherapy radiation, this is one drug which has shown survival benefit with 27% reduction in the risk of death when we are giving Durvalumab for 2 years. So how is it given? So we usually give it as a IV infusion, which is given over 1 hour. So the hospital time will be lasting for 1 to 2 hours for the infusion time. It's once in a month, so very much comfortable for the patient, and they need to come for 2 years. So 24 months is the dose, or we stop earlier when there is unexpected toxicity or the patient is progressing on this drug. So this is about Durvalumab, and thank you.